Hello everyone, I'm Dr. Michelle Hawkins, and today I'll be discussing superficial fungal skin infections. These can be divided into two types, your tinea or fungal infections and yeast infections. Tinea infections are categorized according to the part of the body that they affect. Tinea faciei infects the face. Tinea barbae is a tinea infection of the beard. Tinea corporis involves the trunk and the limbs. Tinea capitis is an infection of the scalp and the hair follicles. Tinea cruris involves the flexures such as the groin or inframammary clefts. Tinea marnum infects the plantar aspect of the hands. Tinea pedis is affecting the feet, and tinea unguum is the infection of the nails. We'll also discuss yeasts such as Candida infection and tinea vesicular, which is a misnomer. Let's talk more about tinea infections. Tinea infections are an infection with a fungus known as dermatophytes. What are the risk factors? These are common in climates that are hot and humid. They're very common infections in children as well as the elderly who are at extremes of age. They commonly infect people whose immune system is compromised. And there's also a genetic predilection for fungal infections in general. Here we can see tinea faciei, which is a tinea infection of the face, also known as ringworm. Here, if we use the language of dermatology, we can describe it as an erythematous, scaly, annular plaque with an area of central clearing that is distributed on the face. Tinea incognita is also a tinea infection of the face, but this type of infection happens when there is misuse of topical corticosteroid creams, such that the local cutaneous immune system is weakened, and then you get an opportunistic infection with tinea. There are some clues to differentiate tinea faciei and tinea incognita, as we can see. Here are the signs of topical steroid and skin lightener misuse. So one of the side effects, as you can see, is atrophy, where you get visible veins and a pinkness to the skin. We can also see hypertrichosis if you had to look a bit closer, and then you can get acne. Ochronosis has several different causes, and one of them is skin lightening abuse. So if you see these in the background of a tinea infection, then you'll know that it is tinea incognita. Tinea corporis, also known as ringworm, is a tinea infection of the trunk and the limbs. We can see here an early lesion, which would be described as an erythematous scaly annular plaque with central clearing that spreads centrifugally, in other words, from the inside out. And then here is an extensive lesion, which is common in people who have a weakened immune system. The diagnosis is through KOH prep. This is visualized under microscopy when you add a 20% potassium hydroxide solution to a glass slide, and you'll be able to visualize these elongated, segmented hyphae, as well as the round spores in the background. The treatment of tinea corporis is often with oral antifungals. So here we've got your griseofulvin. You use 1 gram per day for a month. Itraconazole, either pulse or 100 milligrams per day for 2 weeks. Terbinafine tablets, 250 milligrams a day for 2 weeks. And in resource-constrained settings, you'd use fluconazole, 150 milligrams a week for a whole month. Tinea capitis here is an infection of the scalp and the hair follicles and can be visualized as a silvery scaly plaque on the scalp, which is often called ringworm. Here are some more pictures. There are two different types of tinea capitis. The inflammatory type often heals with scarring, and the non-inflammatory type results in just temporary alopecia. The diagnosis is often clinical, but we can also have a look at the hair root under microscopy and culture. Treatment of tinea capitis is longer than most tinea infections, as you have to get all the way down to the hair follicle. So you'd use your griseofulvin, and for ease of use, you can see we've divided it into child and adult doses. But griseofulvin would be used for 6 weeks, terbinafine would be used for a month, itraconazole you would use for 1 month, alternatively pulse it for just 1 week. Fluconazole you would use continuously for a month. Tinea pedis has also got 2 types. The common type, which you can see on the left-hand side, has these erythematous, pruritic, scaly plaques on the lateral aspects of the plantar foot and in between the toes. And then you've also got your bullous type, which you can visualize as these erythematous vesicles and bulli that convalesce on the lateral aspect of the foot. The differential diagnosis for tinea includes psoriasis. As you can see, these are very silvery, hyperkeratotic or thickened plaques that are often occurring symmetrically on the extensor surfaces of the body and also underneath the feet. So if you ever see a patient with what you think is tinea pedis, you can also just ask the patient to undress and make sure that there are no other plaques on the body. The treatment of tinea pedis can be topical or oral. We use griseofulvin 1 gram per day for a month, alternatively terbinafine 250 milligrams per day for a month. We can also use itraconazole 100 milligrams per day for a month. And in resource-constrained settings, we would use fluconazole 150 milligrams weekly for a month. Onychomycosis is a fungal infection of the nail and the nail bed. Tinea unguum is a nail infection caused by dermatophytes, for example, Tinea rubrum. Onychomycosis can also be caused by yeast, such as Candida albicans, which mainly affects the fingernails, as well as infection with non-dermatophyte molds, such as Aspergillus and Fusarium. The clinical features of onychomycosis include subungual hyperkeratosis, which is excessive production of skin underneath the nail. There's also thickening of the nail plate itself, yellow to whitish discoloration of the nail, and the nails also become brittle and flaky. Here we can see some proximal subungual hyperkeratosis, which is visualized as this whitish discoloration of the proximal nail. Distally, you can see these flaky and crumbling nails distally that are lifting, and then you can also get a superficial white surface on the nail. The differential diagnosis includes psoriasis, which we can differentiate from onychomycosis with pitting on top of the nail. You may also find actual psoriasis plaques, which would give you a clue, and then you can see this salmon-colored or yellow oil drop discoloration of the nail. The diagnosis to differentiate would be by taking some nail clippings and looking at them underneath the microscope, where you would visualize hyphae and spores. Treatment of tinea unguum is longer than any other type of tinea treatment. So you could use terbinafine on the fingernails for 2 months and on the toenails for 3 months, 250 milligrams per day. Alternatively, you can use itraconazole, that is 200 milligrams twice a day for 1 week of the month, and then you would repeat another week of the month, the following month for fingernails, and for a third month for the toenails. Fluconazole, you would give 150 milligrams a week for up to 12 months. Let's talk about yeast infections. We'll be talking about tinea vesicular, which is a misnomer, and candidiasis. Firstly, we'll look at this very, very common skin infection by the organism Malassezia furfur, which is called tinea vesicular. It can be visualized as these scaly, hyperpigmented papules and plaques, often occurring on the face, neck, back, and chest, or it can be hyperpigmented papules and plaques. You can see them very nicely in these pictures. We can also find sometimes some perifollicular plaques, as you can visualize on the last picture. The differentials for scaly hyperpigmented macules and patches include vitiligo, but that would typically be a depigmented macules and patches, and also leprosy. The diagnosis is by doing a skin scrape. You can use a device to scrape some skin onto a slide and add 20% potassium hydroxide to that glass slide. When you look at it under the microscope, you would find these spaghetti and meatball collections of hyphae and spores. The treatment of tinea vesicular can be with oral or topical medication. We would commonly use ketoconazole tablets, 200 milligrams a day for 5 days. You can also use itraconazole tablets, 150 milligrams per day for 10 days. Alternatively, you can use fluconazole 400 milligrams stat. For topical treatment, we use Salsun or ketoconazole shampoo. Candidiasis. Here we have a typical candida infection, which often happens in the intertrigal areas, such as this inframammary neck or groin area. These can be described as erythematous, beefy papules and plaques with a typical satellite lesions surrounding it. Disseminated candidiasis happens when you have a fulminant candida infection that is spreading through the blood hematogenously, and this can be life-threatening. Here we can see web space intertrigo with candida, which is difficult to differentiate from tinea pedis, but as you can see, it's a warm, dark, and hot climate, perfect breeding ground for a candida infection. Paronychia is an infection of the nail bed. So it can be acute or chronic paronychia, and often acute infection is through bacterial infection like staph or strep, and chronic infection is with candida. The diagnosis would be through potassium hydroxide KOH prep. Again, you can see these segmented hyphae and these round spores. The treatment of candidiasis depends on whether it's extensive or a localized infection. For extensive infection, you can use oral fluconazole or itraconazole, and for a localized or uncomplicated infection, you can just use topical clotrimazole cream. How do you know when to use systemic antifungal versus topical antifungals? So we would often use oral antifungals if you've got an extensive tinea corporis infection. If you have any hair or scalp involvement, if you have any tinea capitis, you would definitely use oral medication. If there's nail involvement, the only choice is to use oral medication. We use oral treatment for most cases of tinea vesicular, And of course, if you failed topical treatment, then you would have to go to systemic treatments. Thank you guys for joining me on this presentation. You can leave your questions below and I'll get back to you.